Morning,
computer problems with
and I said, good morning, everyone. I'll be doing a journal presentation along with a case presentation. Uh, so we operated a case yesterday. It was a 55-year male from Tanau, Sukla Gandagi. He presented with chief complaints of PR bleeding, mixed with stool, intermittent. There's also history of C rectum, which he underwent earlier after 6 cycles of neoadjuvant chemotherapy, and then later on went for 2 cycles of adjuvant chemotherapy. It was done 7 months back. And after that, ileostem reversal was done 4 months back. On follow-up, there was suspicious long nodule, which was he was kept on a close follow-up, and he later came with the PR bleeding, the history of which we will see one by one. So if we look at the previous CT, this was the CT after the 6 cycle of chemotherapy, and it shows good response on chemotherapy. There was no mass seen on the cycle, in the CT, but we still plan to do the LAR to see the response. And it was before the chemotherapy. This was the first CT that was the patient was presented with, that he had the long metastasis along with the C rectum, and after the 6 cycle of chemotherapy, the metastatic lesion along with the primary lesion was had disappeared, which you can see in the PET CT, that there was no abnormal uptake in the PET CT in the previous after the chemotherapy. So we did LAR with defunctioning ileostomy, and this was a specimen that was obtained 8 months back, and there was circumferential thickening in the rectum, approximately 10 centimeters from LAR anal wards. There was no ascites and no intraperitoneal mets. So now, on examination on this setting, the general condition was fairly oriented, normally built, performance score of 1, 68 kg weight with height of 162 centimeter. There was no significant findings in respiratory system, and core abdomen was soft and normal. And on PR, there was hard mass at 6 centimeter from anal wards, which was limitedly mobile. Hard mass at 6 centimeter from anal ward, which was limitedly mobile. Sorry. And then pre-ablast, so this time it was essentially normal. On OGD, we can see the recurrence over the anastomotic site was seen on the colonoscopy, sorry. And then on biopsy, on its biopsy, recurrent adenocarcinoma was seen in the biopsy. This was after the second biopsy. On first biopsy, there was no evidence of malignancy. So we did the CT scan, and this was the CT scan of 3 months back, where there was no recurrence mass seen, and there was a small nodular lesion in the posterior segment of the left lung, possibly metastasis, the film of which is not available. And then we followed him up after 2 months, and after 2 months there was 4 nodules in the right lung and 5 in the left lung, that is metastatic lung nodules, and mild perirectal fat stemming with 2 enlarged mesorectal lymph nodes, along with the swelling around the anastomotic region. We can see the diagram file of the CT scan here. If we look over it, here we can see there is a small nodule that was talked about in CT scan. There are some nodules which we have to see in the lung film. And then on further down, so this is the stapler line of the previous, and there is a edematous bowel around the stapler line. However, if we see there is a clear fat plane maintained at the CT scan between the bowel wall and the pelvic floor musculature, but it was not the case intraoperatively. So we diagnosed as a recurrent CA rectum, anastomotic recurrence, and extra-levator APR was done yesterday. There was a hard mass 2 by 2 centimeter laterally at anastomotic site, and invasion to levator and pelvic floor muscle. That's why we had to go extra-levator for two, and there was no ascites and no peritoneal mass, and we obtained the cylindrical specimen. So this is the segment where the mass was present. It was present more laterally, and there are some muscle fiber resected along in the mass. So this was about the case yesterday, and now
Just I interrupt you with one question. So he had the recurrence after 6 months or 7 months?
7 months.
7 months of the
7
surgery.
Yes.
He has got the lung metastasis also right now.
Yes.
Along with the recurrent lesion in the rectum, right?
Yes.
In the anastomotic side.
Yes.
Okay.
And we plan to do staging with this section of the lung metastasis. And now I'm presenting a journal that is the local recurrence after the curative resection for rectal carcinoma. It was published in Open Medicine, which is under the Walter Stewart, in 2016, published from the University of Guri Hospital, Korea, by Jung et al. So in the article in the journal, they have in the introduction, they have pointed out some clinical challenges. That is, local recurrence is very hard to treat. It causes severe symptoms and often fatal, and recurrence limits treatment option and affects the quality of life significantly in the patients. And there have been some efforts to prevent recurrences. That is, the most common one to prevent recurrence is the advanced surgical technique that was given by the Professor Hill. That is the concept of total mesorectal excision, which has shown to reduce the recurrence significantly. And other efforts are the adjuvant and neoadjuvant therapies. And now the acceptable recurrence rate post-treatment are 2.4 to 5.6% in various clinical trials. So current limitation on the treatment of recurrent CA rectum is that the resection is feasible only in 1/3 of the cases, and achieving clear surgical margin is technically challenging in the reoperation cases. And there is also a risk of synchronous distant metastasis, which reduces the resectability and radiotherapy option, as was in our case. So we have to understand about the recurrence because the understanding is key to improve the outcome and forming an optimal care strategies and recurrence pattern and risk factors. It guides the further personalized cancer care. And so their main study purpose was to document the clinical course and prognosis of the local recurrence post-curation, post-surgery, curative surgery, any kind of curative surgery, and assess the impact of surgical resection on long-term survival, and identify the prognostic factor after the local recurrence. So they collected. It is their system to collect data of every patient in their database. So they look for the cases from 1994 September to December 2008. Total of 2,485 patients underwent total mesorectal resection for rectal carcinoma. So this was a retrospective study of prospectively collected data, and it has a huge pool of data. Usually, the surgeries were done TME for rectal carcinoma, adenocarcinoma, most of them within 15 centimeters from anal and hereditary colorectal carcinoma, synchronous CRS, and other primary malignancy, and distant methods at diagnosis were excluded, which made a final sample size of 2,050 patients. And preoperative CCRT was given to 356 patients in this case. To those with T3, T4 lesion or suspected nodal involvement, and for earlier lesion, they went for the upfront surgeries. And surgeries are performed 6 to 8 weeks post-therapy, and follow-up and outcome measures were looked. And primary outcome they looked for in this study was local recurrence, and it was the protocol to keep surveil every patient with CA colonoscopy, CT test every 6 months and annually for 3 years and annually thereafter, and MRI of PET every 6 to 12 months based on the patient status. So there is some terminologies, the classifications they have given to for the understanding of the journal. That is the recurrence classifications. Classification of the recurrence carcinomas. They can be according to the location. That is presacral, anterior, anastomotic, lateral, or perineal. And then axial recurrence is the term they use to define the anastomotic plus perineal recurrence. And then non-axial recurrence are all the other recurrence. Except that of the anastomotic side. So recurrence can be local or metastatic or combined as well, and they have used the diagnostic criteria of major and minor to classify it as a recurrence. That is, in major criteria, it should be biopsy proven, or there can be evidence of bone destruction or positive PET scan. It can be also considered as major criteria for recurrence. And then in minor criteria, the suspicious soft tissue mass in CT MRI and invasion to adjacent organ and raising tumor markers and typical imaging appearance are all kept as a minor criteria. So if more than one measure or more than one minor criteria were met, they kept patient for either surgery or other forms of treatment that will list. So in the results, we can just see the significant portion, that is this p-value less than 0.01 because the results contain a wide variety of variables in the study. So distance from the anal walls was one of the predictor for the local recurrence according to them. That is, if the median distance 7 centimeter had no recurrence, and median distance that is lower than 7 centimeter had significant recurrence in their study. And then another is pathological staging, which is important on the local recurrence. And then another is the pathological N staging, that is N plus disease had high likely to recur according to the study. And again in the result section, the surgical procedure, if we see the sphincter preserving resection versus non-sphincter preserving resection, the non-sphincter preserving resection had high recurrence in their study. And also the initial CA level correlated significantly to predict the recurrence. And the lymphovascular invasion was also one of the predictor. And cell type that is well differentiated, moderately differentiated versus poorly differentiated mucinous carcinoma. The poorly differentiated cell types had significant number of the recurrence according to them. Also, the adjuvant chemotherapy was also significantly associated with the occurrence of the recurrence. That is, patient who underwent adjuvant chemotherapy had decreased number of the local recurrence. So if we look over the distribution of the recurrence in the study, the lateral was the most common one, and followed by the anastomotic, whereas the literature has said that the anastomotic recurrence is the most common one. So this was the recurrent pattern in the study. We can see 78.8. The gray line is of those who received preoperative CCRT, and black line is of who didn't receive preoperative CCRT, and the completely black line is of those who received preoperative CCRT, which also shows the importance of concomitant chemoradiotherapy in the with local recurrence. Here, if we see the significance value, none of the variables had a significant significant change in the axial versus non-axial. That is, none of the variables predicts where the recurrence is going to occur. So this is so they have looked in the pathological T stage, N stage, lymph nodes harvest, CRM, and surgical procedure performed. CA, each and every variable was seen, and the axial versus non-axial recurrence could not be predicted by any variables. So again, if we see that treatment of locally recurrent rectal cancer, according to them, they gave surgical resection for 31 patients and CCRT for 19 patients, and for local recurrence only, and radiotherapy for 4 patients, and chemo only for 34 patients, and then conservative management for 19 patients. And if we see in the next slide, if we see in this slide the Kaplan-Meier curve, So this was the patient. The first curve is of the patient who underwent the upfront surgery after the diagnosis of the recurrent anastomotic recurrence, and then and here we can right out of picture we can see that those patients who underwent surgical treatment has significant overall survival combined with those who had CCRT, neoadjuvant CCRT, and then other forms of treatment. And also the axial, the recurrence at the axial site, that is at the anastomotic site or perineal site, had the significant overall survival compared to those with non-axial sites, according to them. So if we look at the literatures and see the discussion, the local recurrence rate in their database was 5.9%, and surgical resection increased the overall survival after diagnosis of the local recurrence, irrespective of the artery resection. And the good predictive factors in there, according to them, is the tumor stage below T3, axial recurrence, and isolated local recurrence. They opted for chemotherapy in most of the combined metastasis or distant metastasis. And the local recurrence in many literature ranges from 3.7 to 13.7%, and after the introduction of TME, it has decreased massively, irrespective of CT or CTRT. And it is shown higher in a non-sphincter preserving surgery, that is 11.9% versus 6.3% in sphincter preserving surgery. And preoperative preoperative CCRT did not reduce local recurrence rate in other studies, but it did reduce combined local plus distant recurrence if we see in the literature, and there is no improvement in overall survival in CCRT patient, even in the study as well. So, preoperative CCRT, if we look at the literatures provided by them, there are demonstrated benefits and complete pathological response in primary surgery, even in tumor downstaging, and enhanced sphincter preservation, which ultimately improves the quality of life and improve local control. However, the overall survival benefits still remain uncertain, and it has a controversial outcomes in different literatures. So Brinkham et al. They evaluated the local recurrence after previous radiotherapy. It was associated with a significantly shorter survival duration compared with the patient with local recurrence who did not receive previous radiotherapy for the primary tumor. And they also observed that the surgery was significant, and it is also theoretically a good thing that surgery will be definitely easy in those patients who did not receive any radiotherapy in the primary tumor. And the Dodds group findings, they said that the presacral recurrence was most common and anastomotic recurrence was most common in LAR, whereas presacral recurrence in APR. And preoperative radiotherapy did reduce overall recurrence, local recurrence, notably anastomotic recurrence. And current study observation, that the study I present here, they said that the lateral recurrence is highest, anastomotic recurrence is followed by that, and it is reduced in patients receiving preoperative chemoradiotherapy. And presacral recurrence is most common in non-sphincter preserving surgery, as per the many literatures. So if we talk about the upfront surgery in local recurrence, there is established survival benefit. Multiple studies confirmed improved survival with the resection of the local recurrence, that is given in 33 to 33 reference in this article, which was very beautifully shown. And Rohbari et al. They showed acceptable morbidity and curative rates, that is, but still the R0 resection is crucial for long-term survival, even with the distant mets in recurrent upfront surgery. So current study findings, it recommends strongly on a surgery rather than other form of the treatment. So benefit is observed regardless of the RGD status, possibly due to the limited, it may be due to the limited sample size, or there may be limited control group. While going through the journal, these are some of the limitations that I found. The first one is the inherent limitation that was accepted by the authors, that the R0 resection status was not assessed in reoperation cases. So maybe it had significant impact in the survival. So the other limitation could be it was a retrospective design with maybe with a potential selection bias. And the preoperative CCRT based on imaging staging, there is a risk of over or under treatment. That's also limitations in these cases. And pelvic re-irradiation and its effects are unassessed. There are only few patients who received it, and the outcome of which is not shown in the study. And to conclude, the surgical resection of the local recurrence, it prolongs survival regardless of the RZO status. The first line treatment can still be considered for surgery for recurrent disease, for the combined recurrence as well. For the distant recurrence, the chemotherapy can be opted upon with them. An ideal surgical candidate would be tumor stage less than T3, axial recurrence and isolated local recurrence. And poor prognostic indicators may be advanced pathological state, positive CRM, and combined distant plus distant metastasis. So the recommendation would be to screen the distant mets before pursuing patient for the re-resection, which ultimately might benefit for the overall survival of the patient in this case. Thank you.
It's very nicely presented this term. So I have few queries here. Let's come to our case first. What was his final stage? First clinical stage was stage 4 because he had got the pulmonary metastasis in the beginning. And after 6 weeks considered for the chemotherapy, right? Not the chemoradiation. Do you have any idea why it was considered only for chemotherapy, not chemoradiation?
There was also a distant med, sir. Maybe that's why there is.
So the reason was we could have the option with the curative medicine we should go, we can consider chemoradiation for the distant control along with the radiation therapy for the local control. That was not done because the CT scans were obviously a lot of metastasis in the lungs. But fortunately enough, after completion of the 6 cycles in the chemotherapy, the PET scan did not show the lung metastasis. It means those metastases in the lungs are responsive to the chemotherapy. I mean to say that in the context of colorectal metastasis, colorectal cancer, metastatic lesions are quite responsive to the chemotherapy. This is one of the messages that we should learn from our case. So it doesn't mean the patient has a lung metastasis or liver metastasis, that patient is cured. That can be cured. Even quite often in the context of colorectal malignancy, if there are multiple liver metastases, after chemotherapy, the liver metastasis may vanish. That's called the vanishing liver metastasis. That's also a proven fact. Therefore, we should start with the chemotherapy. Now, radiation therapy was not given in our patient because we consider chemotherapy as a first line of the treatment. That is also good. That is also recommended by the SMO and also by the LCCM. Fortunately enough, after the chemotherapy, the patient responded well, both locally and also metastatically. So we consider for the surgery, right, without giving the radiation therapy. So the surgery was done quite good. What was the final stage after the surgery? You did not mention what was the stage. Don't remember, right? So the stage was, so far I remember, it was negative all the margins, radial, axial margin, proximal distal margins. There were no nodes, and that was PT2, I think. As I remember, it's for T2. So the patient was not considered for any radiation therapy. Furthermore, right? So patient did not receive adjuvant radiation therapy because the white T stage were T2 and this was node negative, and the margins were all negative. So therefore, we did not consider in this particular case the radiation therapy. Now the patient was kept under follow-up. He developed some lesion in the anastomotic site, which was taken biopsy twice, which came to negative. Therefore, we advised the patient for reversal of the anastomies, which he underwent quite good. After reversal of anastomosis during screening time, he developed the anastomotic recurrence now. Now this time, he has got the anastomotic recurrence, and he has got bilateral lung metastasis, 4 in the right side and 5 in the left side. Now there is a question, how we are going to proceed? How we will proceed? Patient has got the stenosing lesion at the anastomosis. If we wait for the radiation therapy or chemotherapy, whatever, it may be too late, and that was acceptable on the basis of MRI and CT scan. Therefore, the option we have here is that we go for the chemotherapy, as it was done in the first line, or we go for the chemoradiation, radiation for the rectum and chemo for the lung metastasis. That was the second option. The third option, that if everything is acceptable, we go for the surgery of the rectum first, because that is important for the patient. That may cause some pain or pelvic recurrence. It's very bad. maybe it may lead to incurable stage and the lateral stage. Therefore, we went for the upfront surgery for the rectum this time. I mean, for the anastomosis. Keeping in mind, our plan was that after the surgery of the rectum, we'll give some cycles of the chemotherapy, and if needed, the immunotherapy. We have not checked the status of any MSI or MMR. We have not, it's very important because we don't know whether the patient will respond to the chemotherapy or will respond to the immunotherapy or not. So the role of the immunotherapy lies when it's always very important that in the case of this rectal cancer, we always at least yeah, MMR, mismatch repair, or microsatellite stability is always very important. So if this deficient or is high, then we consider for the immunotherapy. In this context, there is a role of immunotherapy. If this proficient, this PMMR or MSI is low or whatever, so there is no role of immunotherapy. Immunotherapy is not given. So how do we need to face it? Since the patient has already got the reference, he is a potential candidate not only for the chemotherapy, but also if required, he is a candidate for immunotherapy also, if this condition is present in this patient, right? So we must send the patient for either NGS, next genome sequencing, or immunohistochemistry. That's it, very important. Besides that, KRAS, BRAF, etc. Other genes are also should be also considered. Right? This is one point. So now we went for the APR in this context. So the question will be, was it possible to do the sphincter preservation in this case of Hutchin? What do you think? I think the answer will be no, because it's located at approximately 5 centimeters of the anal burst. This is the recurrent mass, and we don't want to take any extra chance of the further recurrence. The decision of making APR was quite big. Now, as you said, the APR of 2 types. One is the classical. It means there's the rectum, there is the there's the external aneurysm, and there's the levator and eye, right? So the classical approach would be we go in this plane, right, without touching the levator and eye. That's the classical APR. But now we have chosen for extra levator. We are doing this plane. Why did we choose the extra levator? Is there any benefit? Now the question comes: if you can do without the without the excision of the levator, why should you go for to achieve the cylindrical margin? That's the point. That means there are some options in the case of recurrent lesions. The better looks like if you do extra margin, excise from the levator, there's the less likelihood that we get probability of the recurrence. But that has to be proven by the evidence. It looks very rational, looks very catchy. Levator and cardiomyopathy, there should be less chance of it. Right? Because we have already done the previous survey. So, do you think there is any evidence in favor of the cylindrical spacing? What is your idea? Do you have any idea regarding that? In such particular case, whether we'll come back later to the journal, but first for this point. Given in this recurrence, will you go for the classical APR or will you go for the cylindrical APR? I mean the extralevator APR.
Specifically in this case, because we obviously could see that there was invasion of the levator and by the tumor. So to achieve an R0 resection, we have to cut the.
So our point was we should at any cost achieve the R0 reception. So for R0 reception, it's better and it has to be better. Now, the next question, why it is very important for a surgeon. So we have got the two levator, right? One is coming from here, and it's coming from here. Let's suppose the tumor is located here. Do you think that you have to excise both levator? It looks quite irrational. Yes, at one side you have to excise, but other side you have to preserve. Why? Because any extra levator excision would require some pelvic reconstruction. Because the incidence of pelvic wound breakdown or the perineal hernia is very high. So ball may fall down, so it may be difficult to close the wound also. So from that point of view, there's a great debate. If you are going to do the extra levator, you have to do the pelvic reconstruction. Because not quite often. In some cases, it will be possible for the primary closure. Quite often, it will not be possible if you excise both sides of the levator. There is the wound gap. Moreover, if the perineal skin is invaded, definitely will not be able to close it primarily. So, the pelvic reconstruction. Now, in pelvic reconstruction, how will you do? Would you apply the mesh, like proline mesh, dacron mesh, etc.? So this kind of mesh is contraindicated because the contaminated mesh. Just we don't go for any sort of mesh, right? If the mesh is to be applied, it should be like micro mesh, also biological mesh. You can do. Or patients, and the authors have even considered for the biological like synthetic mesh, but they often use some sort of grafts, autologous or heterologous, from like bovine pericardium or bovine dermal skin. They take the skin from the bovine and its dermis, and then take a patch of the dermis, and there is the gap in the levator, and they put bridge into like a mesh. But it has been also found that if my rectum, with a graft necrosis or maybe the serum collection here, that will be also problematic for the patient. Eventually, there will be a gap. But sometimes it will hold, but later on it will go into the perineal hernia formation. So the next option will be this autologous tissue transfer, like have done in one case the VRAM flap. Do you remember? The patient was very well. He has the local recurrent mass and also the perineal, not the local, but after chemorrhage.
Recurrent mass after definitely.
Good. So we did the VRAM flap. He could integrate. So one of the options is VRAM flap, but difficulty in VRAM flap is that we're again making a big incision. The laparoscopy is not intensive because you are planning for the laparoscopy there. You did minimal invasive, but again you are making this big incision. There is the benefit of the minimal invasive surgery loss, right? Because you are making this much risk. Right? The second issue will be that there is the chance of the hernia because you are taking out a lot of cells from the abdominal, the peritoneal abdominal wall, right? The next one, the best one should be the gluteus maximus. So the locally available bilateral can be used or gracilis muscle, but I think personally the gluteus maximus will be the best option for the platelet reconstruction. But I think we have to conclude that for if you are planning for the extralevator excision of both sides of the levator, right? So local tissue transfer is very important, and the first choice should be the gluteus maximus. You shouldn't change the position of the patient at the same time. You can do it. Or the next option would be the VRAM, because it's very well, it can cover very well. The meshes should be the synthetic meshes, I think, are contraindicated, this will be used. So this is in the, now the question comes, is there any evidence which shows that recurrence-wise, extralevator approach is better than the classical? It is said, most of the literature say yes, but many literature say no. So they have not found much of the difference. Right? But now coming to this, the article that you have mentioned, very key point that it has said that if you have the option of doing the sphincter preserving surgery, it is always better than APR because there is the wasting in the APR. So the recurrence rate for APR is always higher than the sphincter preservation. So if sphincter preservation can be achieved, it has to be done. That was the stress in this article. In those cases where they have not, there was not the case of the recurrent rate, it was general cases. He said quite often that if the recurrence has to happen, it occurs laterally. Remember, it's very important.
Yes.
Why? Tumor is here, most of the recurrence is lateral. Why do you think the lateral recurrences are coming? It's because the pelvic side wall, where we want to preserve the hypogastric plexus, we want not to injure the ureters. We don't want to go beyond the hips fascia, endopelvic fascia. The temptation of the surgeon will be remaining inside the polypane. So quite often that may not be possible. You can please go inside the major rectum. So there is a likelihood that lateral recurrence is high. So that was shown very classically in the chair of the literature in this journal. Okay. So I think this is one of the tumors where the surgical confidence is very important. If you are doing wrong, then you will have the recurrence. So this should be actually acting on the polypane of what was described earlier in this article, right? Next thing, I think, the next thing that they have mentioned beside the stage, the higher the stage, the local recurrence will be higher, and the synastoma recurrence will be higher. And surgery is the strong prognostic factor. It means you should be a very good surgeon. You should be surgery meticulously very good in order to avoid the recurrence. So one of the fields where the surgeons will be very expert is the field of rectal cancer. Because once recurrence happens, it is very problematic for the patient also. It's a pelvic pain or maybe incurable in the future, maybe we land up on the total pelvic concentration. So the quality of life of the patient goes down. Besides that, he has to carry the stone. One, sometimes two. Like I do diversion, urinary diversion, maybe needed. Now, they did not mention in their article what kind of surgery they performed. Was it a classical APR or was it the extraordinary? They didn't mention. Right? I think one of the limitations I found in the article, but if they have got a large series, I think it was very good. What I want to conclude with this from this today's point, that the win-win situation would be we go with the minimal invasive. You can find or go up to the levator. Quite often what happens in the male pelvis actually, when we're watching from the perineum, in our district we don't do the prone jackknife position, right? We do the equivalent position. So that one team acts from below perineal face and the second team will go from the above. So at that point, the perineal surgeon, it will be quite difficult for him to go into the exact way. If you go further anteriorly, you can damage the urethra. That has happened twice in our center during the whole span of several years, right? If you go more laterally, you can damage some of the structures which are lateral to the pelvic bone. Go more posteriorly, you can damage the bisacral veins. These are the limitations for the perineal surgeon also. So the good option would be you activate the laparoscopy. You can go to the pelvic floor. It's very well visualized in the lateral line. You can make incision from above in the levator line under vision, because for the surgeons who are from below, they may not visualize very properly, but from above it's very clearly seen where is the tumor and how far you should remain away from the tumor. So from above you will make incision over the levator and that will make quite easy the job of the perineal surgeon. So right comment is the minimal invasive surgery. If it is possible, we have to do for in the extra levator, but that will be possible in a case of non-recurrent lesion. With the recurrent lesion, it may be easy to say but difficult to perform because a lot of medicine will be there more in the context if the patient has a safe radiation therapy after recurrence, quite difficult. Or in the front side, further he has prior radiation therapy. So these points have to be noted. Moreover, we should remember the anatomy of the pelvis is very complex. So levator has three portions, right? All of which the rectum, coccygeus, and iliococcygeus. So we must always remember we should take the right tumor is here in the middle. That definitely it may not be necessary to exercise 4 of the levator. At least they said that more than 1 mm the margins. This is big. By naked eye, you cannot define that. So I think that is 2 or 3 split into divider and I has 2 legs side. Either side is going to be in the center. We will eliminate in one side. In one side we exercise. By literature they say is the pelvic bone 1 centimeter of the levator canal. The attachment has to be preserved and less of the levator canal has to be excised. So in that case, definitely for excising both parts, it requires the very good perineal reconstruction, right? Pelvic floor reconstruction. So these things we have to be noted. In our coming to our case, definitely after the surgery, I recommend that this patient should receive the chemotherapy, maybe the immunotherapy once the report of the NGS or immunotherapy is available. Then we have to go with the lung. Now coming to the main point, the lung. Now he has got the 9 pulmonary metastases. Can you say, Dr. asks, what do you think? What are the good prognostic factors and what are the bad prognostic factors for this patient?
There's multiple lung metastases, so that is a bad prognosis.
Yeah. And the recurrence of the disease, right? In a shorter span of the time. So, what do you think? How many metastases good for the patient?
If it is less than 5, right?
So it is said that isolated 1 meta is the best. 2 up to 2 has got the best prognosis. If something is more than 2, then the prognosis goes down. But now we have got the 9 total metastases. We assume that he had responded to the chemotherapy in the beginning. Now he will respond to another chemotherapy now, plus minus the immunotherapy. Then we can come down, lower down the number of the metastases. We can still perform the metastectomy. So the overall 5-year survival after pulmonary metastectomy comes up to the range of 40%. This is not bad. 5-year survival after pulmonary metastectomy in the context of colorectal malignancy is 40%. So that's not very bad. So I think we have to move to a statin because it's quite young.
55 years.
55 only, and we have to do whatever is. Any comments? केही छ तपाईँहरुले? एउटा रिभ्यू पनि यसको लागि हाम्रो लागि पनि रिभ्यू भयो हैन कसरी हाम्रो केस